I'd like to introduce our speaker today, Dr. Paul Gong. Dr. Gong is a board-certified pediatric neurologist who specializes in headache disorders at the Norton Neuroscience Institute Headache Center. He earned his medical degree at the University of Louisville School of Medicine and then completed his pediatric neurology residency at the University of Louisville and Norton Children's Hospital. He completed his fellowship in headache medicine at Cincinnati Children's Medical Center. He has a special interest in adolescent and young adult populations, and specifically in the transition of care from pediatric to adult care for patients with headache disorders. So welcome, Dr. Gong, and I'm going to turn it over to you.
Great, thank you so much. I'm glad to be here, and I'm just going to share my slides. Yeah, thank you so much for the introduction, Dr. McDonald. And I'm really glad to be here to talk about migraine in children and teens. And, there's a lot of headache disorders that we see in neurology, but probably the most common one is migraine. And it's one of the biggest reasons, if not the reason, that I decided to pursue not only neurology, but also headache medicine. So I love talking about it, and I'm really glad I get to talk about it here today. So, oops, sorry. There we go. Okay, so these are the objectives. So first, I'm just going to go through the criteria for the diagnosis of migraine and then some other diagnoses related to migraine in kids. And then we'll go through the pathophysiology of it. This is the basic kind of history and physical that we do for a patient who comes in with a headache disorder. And then some of the more typical outpatient treatments that we use, and then some newer treatment options that are both on the horizon and kind of just now breaking through. So this is a graphic from the American Migraine Foundation that I think just shows the importance of care for patients who have migraine. So it is defined as one of the most 10 disabling medical illnesses by the WHO, and impacts lots of people, 37 million men, women, children in the US. And I think the big thing for me that sticks out here is that more than 90% of those affected by migraine state that interferes with their education, career, and social activities. And I think that's the big thing for me that drew me to the treatment and care of patients who have migraine, is that it's not only the pain part of the disorder and headaches, but it's also the disability that it causes. A lot of missed work, missed school. And I think these are patients who, if you get better, can become very productive, very, happy people in life. And so it's nice to know that there's things we can do for them that can really improve their quality of life. So this is just kind of a brief timeline of what's called the ICHD. I call it the ICHD-3 is the current version of the guidelines for headache disorders. I call it kind of the Bible of headache disorders, but basically it's just a group of headache specialists who have come together over the years to find different types of headache disorders that we as neurologists see. And so I was going to go through some of the definitions of them. They're a little boring, I would say, in terms of they're just kind of bullet points, but I think they're important to know, and I've kind of highlighted the important parts for everyone to remember. So for migraine, the exact criteria for the diagnosis for migraine without aura is that as a patient who's had at least 5 attacks, and typically this is more so talking about adults, but attacks are usually, the headache attacks are usually 4 hours to 72 hours, and that's not including any time that was treated. So it's really untreated time. And then they have to have at least 2 of the following qualities. So unilateral location, pulsating quality, moderate to severe pain, aggravation or causing avoidance of routine physical activity. And then also they have to have at least 1 of the following, which is nausea and or vomiting, and both photo and phonophobia. And so I think the big key is there for us seeing kids is that there's a few differences, which I'll highlight here in a sec. But, overall, a lot of times when we see patients with migraine or with headache, these kind of the things that we look for in neurology is, do they fit these qualifications for that diagnosis of migraine? So the things I highlighted are because in kids, it can be a little bit different. So in children and adolescents, actually, Migraine headaches are more often bilateral than in adults. And I think a lot of us who've seen kids with headaches who have migraine have noticed that kind of this bifrontal or bitemporal region is really common in kids. And that still qualifies them for that diagnosis, even though the criteria states unilateral. And then occipital location, I know a lot of times is sometimes noted as a red flag, but it's actually not really rare in both migraine and in especially migraine in kids. So it's not necessarily something that makes me worried about headache if it's occipital. Then for kids, the attack duration can actually be 2 hours. So if as long as a kid is having a attack that untreated lasts at least 2 hours, and that qualifies them. And then, of course, as we all know, sometimes photophobia and phonophobia, we may need to infer from their behavior to get that part of the diagnosis. So for the definition of migraine with aura, they have to have at least two separate attacks, and they have to have at least one or more of the following fully reversible aura symptoms. And so these are the ones listed that you can see, visual being the most common, followed by sensory. And then the aura itself has to have these specific qualities too. So at least one aura system has to spread gradually. It's usually over greater than or equal to 5 minutes, and it's usually lasting no more than 60 minutes. And then usually it's unilateral and a positive symptom. So we worry more about neurologic symptoms that are more negative in quality as maybe a more concerning sign for possible secondary diagnosis for headache. And then usually a headache is usually accompanies the aura at the onset or follows within 60 minutes. And so that's the technical definition of someone who's migraine with auras. They have these features. And I think the big thing here is they have to have at least two attacks. So if a kid comes in with just one kind of episode with visual symptoms, but hasn't had that since, then they technically don't qualify for the diagnosis of migraine with aura, which can change some management decisions. Then there's chronic migraine. So in the headache world, chronic typically means this 15 or more days a month, and then for 3 months or more. So a lot of headache disorders have the same kind of criteria for the diagnosis of a chronic headache type disorder. And it's the same for migraine. So if you're seeing a kid who's having this, I say half the month or more, and been going on for 3 months or more, then they can qualify for that diagnosis of chronic migraine. And I think a key point here is that the greater than equal to 8 days a month, basically that's, I think, more important for insurance purposes, that, what we say is at least 8 or more days a month are moderate to severe in intensity is kind of how we think about it. But, I think overall, the big key point here is that chronic includes this number, 15 days or more a month, and that's been going on for 3 months or more. Chronic migraine actually is, not too uncommon, especially in the adolescent population. You can see the range anywhere from, almost 1% to 2%. And we do definitely know there's risk factors for developing chronic migraine in kids and adolescents. So socioeconomically disadvantaged patients have a higher risk. And we know that, like what we talked about earlier in the beginning, that people who have migraine, especially kids, tend to do worse overall in other areas of life, including school, but also in terms of socializing and making friends and stuff like that. So I was just going to next go through some of the other types of migraine variants that we see, and maybe give some people a little update in terms of their definitions. So migraine with brainstem aura is the new name for what I think a lot of people know as basilar type migraine. We don't tend to use that as much. Basically, we think about this as another type of aura. So it fits under that it's a subcategory under that fitting of migraine with aura. And basically it's a migraine attack that has aura symptoms that we assume are relating to abnormalities from the brainstem, but without any motor weakness. So usually those can include dysarthria, vertigo, tinnitus, hypsacusis, diplopia, ataxia, and then usually a decreased level of consciousness. So you just have to have two of those. And we can't have any motor or retinal symptoms. And like I kind of put on the side here, we be kind of careful giving this diagnosis because there's kind of subtleties there where there's a type of aura called an aphasic or dysphasic aura that we have to differentiate between dysarthria and then vertigo. I think dizziness is kind of catch-all sometimes. So really understanding what people mean by the word dizziness. Um, and then, yeah, and blurred. And I think the other big key point in these notes is that blurry vision, especially bilateral blurry vision, is a pretty common symptom for people who just have migraine in general. So just differentiating this idea of blurry vision from true double vision. Um, of course, if there's any motor weakness, unilateral motor weakness, that's when we think of hemiplegic migraine. So that's the next part. So it's another, we think of hemiplegic migraine as another subcategory under a migraine with aura. And it's basically a migraine, it's someone who has migraine attacks that include motor weakness, and they have to have at least one other aura type symptom. Usually it's a visual type aura. And then usually the attacks do last less than 72 hours, but there are some patients who do have this and it lasts for days or weeks, and then the deficits can be more permanent. But usually in kids, the deficits, if we do see them, are more reversible, fully reversible. And I think for hemiplegic migraine, if there's a concern about it, I think getting a family history, especially if you're seeing it in a child, is really important because um, there's the phenomenon of a spontaneous or sporadic hemiplegic migraine type, but in kids, oftentimes it is familial. And so I think most of the time we will see that family history. It's autosomal dominant inheritance. So these are, you don't have to necessarily memorize all these genes, but we do know there are specific genes associated with it. And if you're seeing a kid, especially a young kid with concern for hemiplegic migraine, then my bet is that if it's true hemiplegic migraine, then there would be some sort of family history at that point. I think it's also important to differentiate weakness in terms of a migraine attack that there's concern for weakness versus just kind of this dense sensory aura. The sensory aura is usually this tingling numbness, and usually in the arm, but also sometimes in the face or leg. And a lot of times patients will express this sensation of weakness, but really it's more so that loss of sensory input. And so I think differentiating between that versus true weakness is important before making the diagnosis of hemiplegic migraine. Here's some other definitions real quick. So status migrainosus, when we say that, we're really talking about just a migraine attack that lasts more than 72 hours. There's tension type headache, which is more rare in children, more common in adults, but that's more of this kind of band-like tightening pressure. And I think the big thing for it is it's always bilateral, it's not aggravated by activity, and they don't have a lot of the same associated features with the headache like migraine does. So the nausea, vomiting, and no more than one of photo and photophobia. Menstrual migraine or menstrually related migraine, basically it's just a headache that occurs, in close temporal relation to onset of menstruation in females. And then there is a phenomenon, it used to be called aceralgic migraine, but sometimes are now called migraine aura without headache. This is pretty rare in children, but it's just patients having more aura symptoms without headache. And then a big key, I think, for a lot of people, I think you see a lot of is analgesic or medication overuse headache. And so typically what we see here is a chronic migraine type phenotype, but in the history you see patients who have overuse of these acute medications more than 3 times a week. Usually it's closer to that 4 or 5, usually more like 6 or 7 times a week, almost daily use that I see this medication overuse phenomenon. And a lot of times with these patients, just treating with a complete washout tends to help and actually may even, resolve the headaches completely. And then I was going to talk real quick about what's called episodic syndromes that are associated with migraine. So I think a lot of us have seen these. These aren't quite typical of symptoms that aren't quite typical of what we think of migraine, but we do know that are related, and patients who get these types of symptoms tend to develop migraine later in life. So cyclical vomiting is one. It's again 5 attacks of intense nausea and vomiting, and they're usually stereotypical, recurring in a predictable pattern. And the nausea vomiting is pretty frequent, at least 4 times an hour, lasting up to an hour, or at least an hour. And then the attacks usually are separated by a week, and in between they have complete freedom of symptoms. So that's something often we see in kids that these kids, as they get older, develop a more typical migraine phenotype. Abdominal migraine is another type that we see a lot. Again, at least 5 attacks, kind of have this very poorly localized mid-dull kind of pain in the abdomen. And then they have usually anorexia, nausea, vomiting, or pallor. and lasting 2 to 72 hours with some complete freedom of acute attacks. I think the big difference between this diagnosis and cyclical vomiting is that there's not as much of that predictability of a pattern with abdominal migraine. Benign paroxysmal vertigo is a type of headache disorder we see in kids that we think is related to migraine as a subcategory of migraine, that these kids often do develop migraine later in life, and that's more of these attacks of vertigo, usually maximal onset lasting minutes to hours, and can be associated with any of these symptoms such as nystagmus, ataxia, vomiting, pallor. And then a lot of times these kids, when they have these attacks, they are kind of this key feature is they look really fearful. They're really like kind of almost scared because they don't know what's going on. And that is a very typical finding when you see a patient who has this. And then similar is benign paroxysmal torticollis, same kind of thing, but except they have, instead of vertigo, they have this head tilt, sorry, that can last minutes to days, and same sort of associated features. Again, another type of episodic syndrome that we think is related to the bigger kind of picture of migraine, so all in the same spectrum of disorders. So next I want to talk about pathophysiology. So this is what we think of in terms of the timeline of a migraine attack. There's a prodrome that can be a few hours to days before an attack. The aura phase, which is usually 5 to 60 minutes, like we talked about. The actual headache or attack phase, that you have the pain plus all the associated symptoms that we think of. And then this postdrome, often called like the migraine hangover, that occurs usually 1 day to 2 days after. And then not on this picture is in between the post and the prodrome, we call it the interictal period, which is basically the period of normalcy between having symptoms. And that's, really our goal in treating patients with migraine is maximizing that interictal period. But, how I think about it is a person who has migraine is in any one of these stages at any point in their lives. So hopefully they're in more of the interictal phase. But, at some point, within their lives, they're either in the prodrome or a headache, postdrome, or interictal phase. And that's what migraine disorder is. And so in the past, we used to think that migraine was due to vasoconstriction, and that a lot of the pain and associated symptoms were due to this phenomena that the vasodilation, sorry, and then the medicines that we use to treat by this vasoconstriction, and that's how the whole pathophysiology worked. But really that's been shown to be disproven. And really what we know about migraine now is that it's a lot more complicated than that. We think about it more as a disorder of neuronal hyperexcitability. And so someone who has migraine we know it's genetic. We know it runs in families, as everyone knows. And someone who has migraine has these genes that predispose them to neuronal hyperexcitability. And so because of that, there's the opportunity for their neurons to get triggered and start releasing signals that ultimately end up releasing neurotransmitters that we know activate the trigeminal nucleus. So we know the trigeminal vascular system is really important in the whole migraine pathophysiology. And yes, there is some dilation of meningeal vessels, but there's a lot more. There's activations in basically the whole brain, the area postrema, hypothalamus, the thalamus, and even back to the trigeminal system, which is why a lot of patients who have a trigeminal cervical system, that's just why a lot of patients who have migraine also complain a lot of neck pain with it. So, basically all that to say is migraine is a very complex disorder. It's not just a bad headache, which is what I tell my patients all the time. It is a complex neurologic disorder that occurs because someone has this hyperexcitability, and there's a lot of parts of the brain that are kind of firing off, getting activated and causing a lot of the symptoms they have in migraine. And so this is just another way of describing what I just said, where there's all these different parts of migraine that are going on that then lead to the symptoms of for someone who has migraine. And so I often very much tell my patients that migraine is not something you get. It's not something it's not a bad headache that happens every now and then. It is a type of neurological disorder that you have, that you were born with, and the headaches are just a symptom of it. So how I usually word it is that you get headaches because you have migraine. and you have migraine because it's in your genes. You were born with it, and that's just how you were, and that's how a lot of people in the world are. And so I think that's really important to me because it underlies the importance that we have to treat the disorder. And it also kind of hits home that point that it is something that can cause a lot of disability. So a lot of people I feel like who have migraine, their symptoms are brushed aside because they think it's just a bad headache and you should just kind of push through it. But understanding migraine as the disorder, I think, helps people understand that it is something that can cause a lot of disability in someone's life. All right, so let's move on to just examining a patient who comes in with headache. Like I talked about, headache is just a symptom, and migraine is a common reason for headache, but there's lots of other reasons that someone can come in with headache. So there's a lot of red flag symptoms that have been thrown out. I think these are the more common ones that people think of. So this worst headache ever, thunderclap type headache, definitely in young kids under 3. If you have what's called a prolonged aura, which is an aura lasting more than an hour, and that's new. Early morning vomiting, that's intractable. Abnormal neurologic exam, of course, and then any sort of provider concerns due to systemic symptoms or from the patient history. And then you can see here these more yellow flags. But really, I think for me, the biggest thing when you look at the literature is this abnormal neurologic exam is what seems to correlate the most with the association with a secondary pathology in someone who has a headache. But if you look at the actual guidelines from the AHS, this is what they recommend. So as they say, the top point says it's not necessary to do neuroimaging in patients with headaches that are consistent with migraine, which is why I think it's really important to understand the diagnostic criteria. So that meet that criteria for migraine and who have a normal neurologic exam. And that's a grade A, strong recommendation. So what I often tell my patients is if you fit my criteria for migraine, if you have neuroneurologic exam, and especially if you have a family history of migraine, then I am not worried at all about a secondary or another reason for your headaches. And I have no reason or concern to get any more testing of your brain. And like we talked about here, some of the reasons that they have, recommended to consider for imaging, which is a lot of what we already talked about. But I think ultimately for me, when I see patients, the biggest thing is, do they meet criteria for migraine? And do they have any abnormality on their neurologic exam? And those are the things I rest on the most to guide my decision making about whether imaging is necessary or not. And then I brought this up a little bit earlier, but does occipital headache need imaging? I know a lot of times people get worried about occipital imaging, occipital headache, and I understand because there's the concern for a posterior fossa abnormality or tumor. But really, if you look at the literature, these children are more likely to undergo neuroimaging, but it's not necessary if it's just occipital headache alone. So again, if there's no other concerning features on history, and then again, in the setting of a normal neurologic exam, even if they have purely occipital headache, you can defer neuroimaging in that case, and it shouldn't be an issue. And I'm sure everyone already knows this, but parts of a headache history are always age of onset, location, frequency, and then onset, duration, character, severity, the course of it, prodrome or aura symptoms, which we talked about a little bit. And then I didn't do this so much now in my current practice, but in Cincinnati, we would do a PED-MIDAS score on every patient, which I do think is a useful tool for disability. So if you don't know what PED-MIDAS is, this is the exact questions are asked for PED-MIDAS, and it's basically a way to gauge in children the level of disability that their headaches are causing. So it's a good marker, I would say, for how a patient is doing. I would say the primary marker we use within headache medicine is frequency, right? How often are you having headaches? But this is also another marker in terms of how much are your headaches impacting you. And like you can see here, it just talks a lot about missed school, missed activities at home or social. And this is basically how you score it. So once they answer your question, they get a score. And based on the number, we can grade the disability. And that's just an easy way to mark, how well they're doing or not well they're doing, and then how much they're either improving or worsening over time. And then within the headache exam, I do think these are, obviously you want to do a full neurologic exam, but otherwise there's other parts. So I think the ophthalmologic exam is one of the most important parts, checking fundus and optic discs. But other things can sometimes you can figure out if there's other reasons that are exacerbating or causing worsening of their headache. So TMJ disease, mucous membrane disease, if they're dehydrated, any sort of sinus issues. Hypermobility, if test for that with the Beighton score, is often associated with migraine. And then any sort of muscular tenderness in the shoulders or neck often is associated with worse or more severe disease in migraine. All right, and then next I want to talk about the outpatient management of migraine. And I think a lot of people are probably know this, so I'll review a lot of it. But I think understanding this part is really important for a lot of patients to move forward and get better. So in terms of treating an acute attack of headache in someone who has migraine, the key pearls for that are here, which are always treat early. Always use the appropriate dose. Oftentimes, patients will underdose themselves with medicines, which can lead to incompletely treated attacks, which we know is a risk factor for worsening headaches. Obviously, there's always the option to use non-oral routes of administration when patients have nausea, and then we always want to treat as quickly as possible. So what we know is that treating an attack early and aggressively tends to lead to better improvement in the acute setting, but also a completely treated attack over time can also help reduce frequency. And like I said before, vice versa, we know that a risk factor for chronicifying the headache disorder is incompletely treated attack. So we always stress in our patients to treat early and treat aggressively. So this is how we think of acute treatment within the treatment of migraine in kids is we usually try to first use like a NSAID type medicine. And so ibuprofen or naproxen are good options. I sometimes also use diclofenac. I do use weight-based dosing. Ibuprofen I usually max out at 800 to 1,000 milligrams, and then naproxen I usually also max out around like 750 to 1,000 milligrams in kids. But like I said, we always use higher doses, which oftentimes scares people, but the higher doses are more effective, and kids tend to tolerate them well. And then we often say the kids can repeat the medicine within 3 to 4 hours, even the higher doses. And that's again getting to that point of treating early and aggressively. You really want to get ahead of the headache and the symptoms before they are too prolonged. But we do want to make sure kids aren't treating too much. So that's no more than twice in a day, and then no more than 3 days per week. Those are the general rules. Triptans we do add, and so for that we usually use, as you can see the list here, there's several. So zolmitriptan, amitriptan, rizatriptan, sumatriptan. So I would say that usually rizatriptan and sumatriptan are the most common. Rizatriptan is the only one FDA approved in 6 and up, and sumatriptan and these others are approved 12 and up. But all are pretty similar in terms of effectiveness. Rizatriptan is nice; it comes in a melt. So those who can't especially the younger kids who are, under 12, who can't swallow pills, rizatriptan is a good option. And so for triptans, again, the ideas of it are you want to treat early for a severe attack. So I usually tell my patients there's two different ways you treat. For a more mild attack, you use your NSAID. For a more moderate to severe attack, you use the triptan. And you can use them with the NSAID. So I often do encourage patients, especially for really severe attacks, to use them together. There's lots of evidence that show that they work better together. But again, with the triptans, you can't use them too much. So you can repeat them 2 hours later, but then no more than twice in a day. And usually no more than 6 to 8 days in a month. We don't want patients using a triptan. And so these are kind of the two mainstays for acute treatment in kids that we tend to use. And like I said, I usually always start with the NSAID, but then still offer a triptan, usually either Ryza or sumatriptan for the patients to have available, and then allow the patient then and the parent to, based on the type of headaches that the patients have and then the pattern to determine what they want to treat with and how. So definitely for triptans, this is more important for adults, but there's definitely contraindications. So any sort of vascular disorder, so stroke or MI, any sort of clotting disorder, really, even like a peripheral vascular disease, we don't want to use triptans and due to the potential risk that it could cause vasoconstriction. And then uncontrolled hypertension is also a risk factor or absolute contraindication. And side effects, most of the time is pretty well tolerated. I would say the main ones are the sleepiness, and then definitely this feeling of tightness in their jaw or chest, sometimes their throat. That's the tightness sensation seems to be the thing that will make patients shy away from wanting to take it. But it's always good to let patients know when you're prescribing triptan that these are possibilities. Moving on to preventive treatment. So for kids, typically we think of preventive treatment when their frequency is 2 or more a week. A lot of literature, especially in the adult world, starts preventive meds at more than once a week, 4 or more a month. But at least where I trained in Cincinnati, we would always do 2 or more a week. And that's, I think, mostly because of the results of the CHAMP trial, which showed that a lot of these preventive meds that we used, the typical ones, were as good or no better than placebo. And so we do know there's a huge placebo effect in kids. And so with prevention meds, especially the more prescription type options that do have a lot of side effects, we tend to try to not start those too soon or too quickly, knowing that, treating, like we said, treating acutely, completely treating attacks each time, can alone reduce frequency and disability in patients who have pediatric patients who have headache. And I think this is a key point that I often tell my patients is that whenever we treat migraine, it's never to cure migraine. So migraine is not curable, like I talked about earlier. It's a genetic neurologic condition that is you're born with and you have the rest of your life. It's just the way, how I say it is, it's just the way your brain works. It's a little extra jumpy, extra hyper excitable. So because of that, it's not necessarily, we're not trying to cure people from migraine, we're trying to prevent symptoms, prevent headache and other symptoms. And that may mean that they have symptoms still, intermittently, even a few times a month. But our goal is that we reduce the amount those symptoms cause disability in life, and we make sure they have a treatment plan for those symptoms that allows them to treat them effectively and move on with their life, basically, without having to be concerned about their migraine disorder. With preventive treatment, the goal is always to start low and go slow. That does help with side effects and adherence. And usually what we tell people is we want to evaluate response 6 to 8 weeks after getting to the goal dose. So oftentimes I will work patients up over a week or two, or a month or two, to a good goal dose that's tolerable. And then after they get to the goal dose, I'll say, let's see another 6 to 8 weeks on it. So definitely preventive treatment, I tell patients, is the long-term plan. It's the months, not weeks plan. And it's definitely the goal of reducing frequency and severity and duration, but over time. And I always try to tell my patients it's not something that's going to happen as soon as you start taking the med, or even after a month. It's, it always takes time and we have to be patient for it. And like I mentioned, the CHAMP trial earlier that did show that a lot of the typical preventive meds we use are, placebo is as good or even sometimes better than them. Our goal is never for patients to stay on meds forever. And so I always tell my patients the goal is to get you better and then get you off. And so usually after a few months, and 2 is probably the minimum, if they're well controlled, then we can start talking, at least considering weaning off the medicine. So there's a few options for preventive treatment. So the first are non-pharmaceuticals. So these are called nutraceuticals, basically vitamins that are found in foods. And I think these are pretty common and popular within the pediatric population, just mostly because of their lack of side effects and the safety. And so these are 4 that we used a lot in Cincinnati, and that I think have good evidence for use in kids. And so vitamin D, we would aim for a level of more than 40. So we would check a level first and then start it. And so if they're less than 30, we typically give 8 weeks of 50,000 units once a week, and then 2,000 units once daily afterwards. And then if they're between 30 and 40, then we just do 2,000 daily. And if they're over 40, then we wouldn't supplement. And that's typically how we did it in Cincinnati. For riboflavin, in adults, they use much higher doses, but in kids, we typically use 50 BID, and we did a BID type dosing just because there's one study that showed the GI tract can really only absorb 30 to 40 milligrams at a time. So we like to split the dose up. And then coenzyme Q10 definitely has evidence in adults and kids. Actually, in Cincinnati, they did a study that showed that especially patients who are deficient in coenzyme Q10 on lab levels tended to have benefit when supplemented. So 100 milligrams daily is a good dose to start at. And then for folate, we usually just recommend a multivitamin that has at least 400 micrograms of folate. My view on the nutraceuticals are they're a good adjunctive treatment. I think for patients and parents who are hesitant to start a prescription medicine that we know is used for migraine and has evidence for use, then I think this is a good option. And I think for an additive therapy for someone who's doing, having improvement, but not quite all the way as much as we would hope. Once starting a preventive med, a vitamin is a good idea. And the two I tend to use mostly are riboflavin and coenzyme Q10 in my kids. And then you can try to prescribe them, but oftentimes patients will have to just buy them over the counter. And here's a table of the preventive meds we typically use in kids. So there's not as many approved in kids as there are in adults, of course. So I would say the two most commonly used, the two that I always offer first are amitriptyline and topiramate. Both have class A evidence levels. Again, we use weight-based dosing, so 1 mg per kg per day for starting dose amitriptyline. Topamax is usually 2 to 3 mg per kg per day. And then the side effects are, of course, for amitriptyline, the main ones are sedation, constipation, increased appetite, weight gain, and sometimes it can cause some dry mouth and eyes. And then topiramate, the big things are the paresthesias, the numbness, tingling in the fingers, the anorexia, decreased appetite. It can cause some decreased sweating, so important in a lot of your adolescent patients who are in sports. And sometimes there's that risk of kidney stones due to the risk of causing metabolic acidosis. Both of these meds, I would say, are overall well tolerated in kids, especially if you start low and go slow. And so how I typically titrate up is every 2 weeks. So that's how I was taught in Cincinnati, and I think I found that has the best results for adherence is that if we start at a lower dose and go up to that dosage of that 1 mg per kg or 2 to 3 mg per kg, but over every 2 weeks going up on the dose, that tends to make the medicine a little more tolerable and patients tend to do better on it. Other options are valproic acid. We don't use it as much just because as a daily preventive, just because of all the side effects that you can get from it, and tends to not be as well tolerated by kids. And then cyproheptadine is a good medicine, I would say, for young kids, kids who cannot swallow pills. So I don't tend to use it as much though once kids get to the older childhood ages, so usually 7 and under is kind of when I think of using it. And it's mostly because with the weight-based dosing, when you get to those higher doses, it's really intolerable. Kids tend to get really sleepy on it. It's a BID dosing oftentimes, so having them have to take this big dose right before school is usually not preferable. And then the weight gain can be pretty significant on it. So I tend to stay away from it and once kids get older. Propranolol doesn't have as great of evidence for kids. I know it's a mainstay in adults. I don't, it's not that I usually reach for topiramate and amitriptyline first, and think of propranolol as a second or even third line option. The side effects obviously are what we know from the decreased heart rate, so it can cause some fatigue, exercise intolerance, orthostatic hypotension, and some issues with mood, and don't really want to use it in patients who have a history of severe asthma because it can definitely exacerbate it. So obviously these are the ones that we typically use. The other one I didn't list here that sometimes we use is levetiracetam or Keppra, another option for a preventive treatment that sometimes I reach for if patients have failed topiramate and amitriptyline. So when we think of patients who are chronic, who've then failed multiple other preventive meds, then we do think of Botox. And Botox is a great treatment for migraine. It's really commonly used. We do it a lot. It's 31 injections in the forehead, side of the head, back of the head, neck, and shoulders. Very shallow injections. Usually I tell patients the procedure itself takes less than 10 minutes, very quick. And a lot of times you'd be surprised how well adolescents can tolerate it, honestly. And I've been surprised at least. I think it's because the injections are very shallow, the needle is very small, and it's very quick. So we know that Botox tends to work because it acts on that trigeminal vascular neurons that I talked about that are very much involved within the pathogenesis and pathophysiology of migraine. And even though it's not technically approved for kids, it's FDA approved only in adults. We do use it in the pediatric population, and the data is limited, but the data does show that it can help. It can cause a reduction in frequency and disability in patients who have chronic migraine. So we tend to use the same guidelines for use as an adult, where if they failed two or more preventive meds, so like they failed a amitriptyline and topiramate, then I think Botox is one of the first options we think of. It's every 3 months, so I always tell patients it's a commitment. You got to come in every 3 months, and typically patients don't tend to notice the benefit till after the second or third round. So that's something I also make sure patients know is that you may not see a benefit after the first round. So even after you get it, the first round for the next 3 months, you may notice no benefit, no difference. And then hopefully after the second or even third round, you start to notice a difference. So it's definitely a commitment on the patient's part to see it through, but it does tend to help those who kind of fit this criteria, this picture of chronic and have failed other treatments already. Lifestyle factors are always important for treatment of migraine. So hydration, limiting caffeine use, exercise, eating a well-balanced diet, sleep, keeping track of headaches. Last thing, in terms of food-wise, eating regular meals, not skipping meals, which is a big trigger for headaches. That's something I always counsel my patients on every single visit is the lifestyle factors, which can be just as important, if not even more important than a lot of the medicines we can give them. All right, and the last part of the talk is the newer treatment options that are in the pipeline and are already being used in a lot of patients. So the first are definitely the anti-CGRP monoclonal antibodies. So CGRP is calcitonin gene-related peptide. I'm sure most people have heard of it at this point. It is very important, we know, in the pathophysiology of migraine. And some very smart people figured out that if you block it or block the receptor, it can be used to not only treat headaches as needed, but also be a preventive treatment. So there are three main injectable pens that we use, I've listed here, that are very effective, that have been used in adults extensively now and shown to be safe and effective. And lots of the studies now, which I was a part of some in Cincinnati, are going on for kids. And 12 and up will be the next indication that I hope here soon the FDA will approve, which will be a huge game changer. We still tend to use the same guidelines as Botox, I would say, for getting these meds approved, which is failed two or more of the more typical preventive meds that are used, so amitriptyline, topiramate, main ones. But for those patients who and they don't have to be chronic, which is a great thing for these who have just failed two other preventives, who are still having lots of headaches. These are great options. They're very well tolerated, which is I would say the interval of use, which is once a month, and then how well tolerated they are, the biggest draws for them. So they can have some injection site reaction is the biggest side effect, and then the Amivig or Erinumab that can cause some constipation because that one tends to block the receptor for CGRP, which can cause a little bit more side effects. And then, like I said, this is actually from a paper that's written by Dr. Gelfand and some other people in the headache world, pediatric headache world, who listed some recommendations for use. And it's basically what I already talked about, 8 or more days of headaches per month, high disability, failure of 2 or more preventive treatments. And then, more so in post-pubertal adolescence, which is typically when we would even, a lot of times in younger kids, they wouldn't quite even fit the criteria to have this used in terms of their frequency or severity. But there's some concern of the long-term use. We don't quite know how, CGRP is pretty ubiquitous across the body, so we don't quite know what it does over long term. So that's why we often say post-pubertal adolescence. And then there's the G-PANTs, which are an acute treatment. So again, they block CGRP, they block the antibody, and these are small molecule oral. Most of them are oral medications that do block CGRP and can help acutely in the moment. So the two that we use are ubrogepant, rimegepant are the two main ones. There's a preventive treatment called Qulipta, or sorry, atogepant. That's a daily medicine that you can use. But these are just another type of CGRP antagonist that we do try to use in kids. Oftentimes we have to fight insurance for them. And then it seems like they're pretty much in the pipeline for approval in the hopefully coming months or a year or so. Um, Side effects of the G-PANs tend to be some GI upset, nausea, and then sometimes a little bit of drowsiness. But overall, they're pretty well tolerated and actually tend to be more well tolerated than triptans. All right, and then the next part is neurostimulation devices. These have grown in popularity over the last few years in terms of treatment for headaches in patients who have migraine. So I think the main one we use, sorry, the slide kind of got cut off, is this one called, it's a neuromodulator, it's called Ren. It's the brand name is called Nerivio. It's an armband, as you can see in the picture, that is able to be used via Bluetooth. You control it via Bluetooth on the phone, and it's used for both preventive and acute treatment. And basically for acute treatment, you get a 45-minute session of a stimulation in the arm. And the reason we think it works is conditioned pain modulation, which is basically a stimulation in a site remote from the pain tends to help disrupt those pain signals that are going on elsewhere. So it's used as needed, and it can also be used as a preventive if you use it every other day. It's really commonly used in kids as a well-tolerated treatment, and they just got indication recently of it used to be only 12 and up, but they just recently got indication for 8 years and up. So and there is a cost to this, and all these neuromodulation devices do have a cost just because insurance doesn't usually like to cover them. But for patients who are able to and want to pay for them, they tend to be a good treatment that's well tolerated and very low side effects, and that do tend to work, are effective. And this is just a slide kind of showing the difference between TENS unit and REN. They're similar but different, and it's, for me, a good way to try to explain what it's like to patients. A lot of patients have heard of at least TENS units. So I say it's kind of like TENS, but a little bit different. Non-invasive vagus nerve stimulation is another type of treatment. It's a device you put on your neck. It's approved for 12 and up. The brand name is called gammaCore. It can also be used for acute treatment and preventive treatment for migraine in adolescents 12 and up. And you do like two-minute stimulations on the side of the neck. This is what it looks like, the device, and then that's how you use it. Just put it at the side of your neck. Another option, again, there's a cost factor. There's a prescription form you fill out, but usually insurance doesn't cover it. So patients have to be willing to pay for it usually. And then transcranial magnetic stimulation, just another type of neuromodulation device. Savi Dual is the brand name. This one you kind of put in the back of your head. Here's a picture of it. And let the stimulation do its thing to help treat headaches. The last thing I'd want to talk about at the end is treatment preferences and perceived quality of existing outcome measures. So there's lots of studies that do show that the perception of the quality of the options for treatment, and then the addressing of the preferences of treatment among children, adolescents, and caregivers is important in treating migraine for kids. So looking at what is important for caregivers and patients and kids, symptom relief, the trade-offs between side effects and relief, and then making sure care is child-centered. And so basically, in terms of what they find most important in treatment of headaches and migraine is reduction in pain intensity, not necessarily always complete relief of pain, is the most important goal, but also reduction in non-pain symptoms. And I think that kind of goes back to the idea of migraine is much more than a bad headache. A lot of times patients will say that the associated symptoms to headache, the other symptoms of migraine besides headache, are even more so disabling than the headache itself. So always asking about those, looking for those in terms of determining treatment plan, I think is important. And then always acknowledging side effects. I always bring up options to my patients. Especially when talking about preventive treatments, I always present at least two options, and I talk about all the side effects because I think it's important for patients to know that that side effects are important and that they have a ability to determine what they want to try and tolerate. And side effects, I think, are often overlooked in kids in terms of the options and treatment preferences. So I think it's really important to outline them and give kids and caregivers a choice and what they would be willing to tolerate for treatment. And then child-centered care, which I think is going back to what everyone already does, is understanding the whole picture of the patient. Can they swallow pills? Can they not? Do they have other comorbid disorders that are affecting decisions for treatment? Always keeping those things in mind when determining what types of treatments you want to give them for their headaches and for migraine. All right, so these are my references. And any questions?
All right, Dr. Gong. Questions. How long is a washout of a medication? 4 to 6 days or weeks, or what do you think?
Yeah, so 4 to 6 weeks is typically what we do, which is typically really hard for these patients who have medication overuse. And so patients can afford it. That's where I think something like Narivio or the REN device, the armband, fits in really well. Something they can use that doesn't contribute to medication overuse, but can still help provide relief. Otherwise, I tell patients, just try to drink a lot of electrolytes and things like that. But I do often warn my patients who I do a washout on, like, it's going to get worse before it gets better. And I tell them in the next day or two, you're going to have a really bad headache. But what we know is if you push through, lots of times, even patients who have chronic daily headache, they can have up to a 50% reduction in their headaches by the end of that washout, the 4 to 6 weeks. So that's, typically what we do is 4 to 6 weeks of no acute medications.
Okay, and can you reiterate about side locked migraine?
So yeah, so we call it a side lock headache is a type of headache that is just purely one-sided. And I think this is difficult because oftentimes headaches, the headaches that people who have migraine experience are unilateral, but specifically in kids, it's a little bit more unusual, right? Headaches are usually more bilateral, bifrontal, bitemporal. So even in adults, if we hear of a side locked headache, meaning headache always on one side, that does tend to trigger some red flags for us, and we will often image. I think for kids specifically, that's pretty unusual. So I think there's a role for not doing imaging if their exam is normal and they otherwise fit criteria for migraine. But me personally, I think just in general, if I hear about a side locked headache in a kid, I tend to jump to imaging.
Okay. And is there any role for a sphenoid block in peds?
Yes, so we think of a sphenopalatine ganglion block as acute treatment of headaches for something like status, right? The status migrainosis, more than 72 hours of headache. SPG block can be used. I don't tend to love it because it's not as well tolerated in kids, but it is a option, and you'd have to. I don't usually do them, but I think anesthesia can sometimes do them.
Okay. And can you get over overuse rebound migraines from too many triptans, or is it more of an over-the-counter concern?
Good question. Yeah, it's both NSAIDs and analgesics in general, like Tylenol, and also triptans. Yes. So the newer meds, the Gpans, so that's like the Ubrelvys and Nurtecs, we don't think yet can cause overuse, but for sure the triptans and the NSAIDs do, which is why we have that limit of 3 days a week, 8 days a month for triptans, 3 days a week for NSAIDs, 8 days a month for triptans, trying to keep to that limit to prevent the development of overuse.
Okay. And so the CGRP meds have they directly trialed them against triptans and other migraine therapies?
Yes, so not the injectables, as far as I know, were not directly compared to other preventive options, at least in kids and maybe in adults. I'm not aware of anything of studies that directly compare them to like Topamax and stuff like that.
Mhm.
The Gpants, the acute meds, they have been in adults compared to triptans. And actually, triptans are superior than Gpants in terms of
Really?
effect. Yeah, so triptans work better, but cause more side effects. So what I often say is people sleep on triptans. I think triptans are great. There's 7 of them. You have tons of options. I think people get caught up in the new and shiny meds, which are like the Gpans. They still work, but triptans at least the evidence shows, are better. As long as patients tolerate the triptans, I tend to keep trying triptans. Like if a patient even tried one or two triptans, if it wasn't an issue of side effects, it was more issue of ineffectiveness, then I would tend to stick with the triptans before moving to the gepants, especially in kids where insurance is an issue.
So even with FDA approval of some of these new meds, it might not change your acute treatment.
No, so my acute treatment for using triptan for gepants is more so based on tolerability than effectiveness.
Okay. All right, that's all the questions we have today. Thank you everyone for joining us.